Right. Hi, everyone. As we said, unfortunately, right at the last minute, Andrew wasn't able to be here, which is a terrible shame considering the research that's been presented today, because he's a patient with a surgical wound, and as part of his whole process, presenting and discussing it and the journey that he's been through is part of his recovery as well. He suffers, both him and his wife, from post-traumatic stress disorder from the whole situation, and this was sort of part of his treatment. So I'm giving you his opinions here, and I will sort of interject a little bit of more information that he would have done during his presentation. So a bit of background about Andrew. Andrew's a 46-year-old guy who works in a very important job, which was very physical. He works in a company that flies off around the world clearing up oil spills. So when there's a big oil spill, he's one of those people that goes off and helps to sort everything out. Christmas Eve in 2013, in the evening, he suddenly, after having absolutely no symptoms, had severe abdominal pain, asked his wife to call 111 for advice, and they dispatched an ambulance. He ended up in another hospital, not the hospital that that I'm from, but one that's very local to us, into A&E, went onto a ward, on into intensive care. Nobody really knew what was going on. They were watching it, thought it was cholecystitis that he had. Eventually, he was very, very unwell, and his wife was told he wasn't going to make it till the next day. And he was moved to Southampton under our general surgeons to try to reach some sort of diagnosis. And the diagnosis that he actually had eventually, after some time, was that he had 4-quadrant necrotizing pancreatitis from gallstones. So he really did end up in a big mess. And as you can see from his slide here, he was in hospital for approximately 7 months. The reason he wasn't in longer is we were able to get him home with support still from the hospital rather than handing him over to the community. In that time, he had CT scans, as you can see, 14 of them, 2 MRI scans, 4 trips to intensive care, and that was for sepsis. So unfortunately, during all of this time, he had surgery, ended up with an open abdominal wound, which they fitted a vicryl mesh into, but he continued to get infection after infection and ended up with spontaneous fistulas appearing on his body. So he has spontaneous fistulas, one in his groin and a couple on his back, which continuously leak what I can only describe as gunk. It's nothing that anyone can work out what it is, but it's brown and thick, and sometimes it's red, and quite frequently, unfortunately, he has food pop out of them. So we have peas pop out into the little colostomy bags that he has. So he had all of these things going on, 3 operations, and he was intubated but conscious for 5 days, and that in itself, as an experience, was horrific. And it's silly things, or what we would class potentially as silly things, that really affected him. So, for example, I think the reason he's put that in is one of the stories he tells quite frequently is the fact that he had the tube in, and sometimes in intensive care they wiggle the tube just to make sure it's okay. Well, when you're going to do that to somebody that's awake with a tube in, that's quite frightening. And nobody really told him before they wiggled. And that's one of his biggest memories from his experience in ITU. That and the very noisy bin, the lid of the bin being slammed down. That really, really irritated him, but he couldn't say anything about it. But that was another one of his issues. So he also went on and also developed several infections. So he had a pretty rough time. And this is what we ended up with. Very large abdominal wound. And with Andrew and the team, we always sort of try to use a lot of humour because we've been through hell and back with him. He always gives it a name, whatever the wound looks like. So we've been through many things, and this was his Christmas pudding phase, as he called it. So we ended up with this huge open abdominal wound. He couldn't quite get over the fact that they couldn't rejoin the muscles. So, the muscles are retracted and back, so they put the mesh in to hold the bowel in place. We also had a large area of necrosis, as you can see on the left-hand side of that picture, and quite a lot down the bottom, which was underneath the mesh and came through the mesh, which really frightened Andrew. He didn't know what was going on because he was expecting it to look clean, and it didn't. So that was another thing that we don't prepare them for. And also, as was said earlier, sometimes the surgeons or the teams that go and see the patients don't always think about what they say when they're discussing what they're going to do and their plans. So, for example, when they came and said, "Oh, that's a bit of a dead bit in the middle," when you hear that and you're a patient, that's not really what you want to hear, and you don't understand. So it took a lot of time for him to understand what was going on with him. We used topical negative pressure on Andrew to start with because we had a mesh over an open abdominal wound with bowel directly underneath. And really, what else could we do? We don't have an awful lot of options in that situation. Topical negative pressure is contraindicated with underlying vessels, and with the vicryl mesh we've only got a short period of time to heal the wound. Unfortunately, in this case, it was a very difficult time because he kept continuously getting a sepsis and ending up back in ITU, so the healing was very, very, very slow at the beginning. But what Andrew found is that he felt very safe with the topical negative pressure on, so he felt that it held everything together and held it all in. So for him, that was a big thing. Originally in our trust, we just used the old KCI ATS systems, which were wheeled around on drip stands, which weren't the best thing. But subsequently, we went over to use a different product, the Renesis pump, and that one was used, the mobile, the Renesis Go, so he was able to walk around with it. But just really, for us and for Andrew, it's just getting people to understand why the reason that this slide is up for him. I'm trying to think of his perspective on this, and what he tells us all the time is the faces of people when they see a wound like this. So we have a lot of experience and a lot of literature on what it's like and the quality of life for patients with pressure ulcers and with leg ulcers, but we don't have that information about patients that have surgical wounds. And this is a huge thing. It's right under his nose. It's right there in front of him every day. And it is a lot of people that look at the wound just using facial expressions and gasps. He always used to say how people used to gasp when they saw it. So it would be a sort of quite a shock for him to see other people's reactions. But we did manage to get quite a long way with the wound, and the picture on the left was his last time we took the pump off after healing it with the topical negative pressure, the full system. And as you can see, that's August 2014, so that's 8 months after the original injury and the original wounding. So this is 8 months of having a surgical wound, and the majority of that time having been in hospital. And I'm not sure if you can see at the bottom on the right-hand side of the picture, that's all exposed bowel. So the bowel came out through the mesh, and it was, peristalsis was totally visible the whole time. You could see it really moving, and it was a real difficulty for us as clinicians because we didn't really know what to do and what to put on. So I used a double layer of Mepitel underneath the topical negative pressure to protect the area. And I was very reluctant to do anything else, but we decided for his sake, because the topical negative pressure for him gave very similar reaction to how the patients in the study that earlier were discussed. He found it quite embarrassing, the noise when he was out. He loved the mobility of it. He loved the feeling that it was nice and safe, but he didn't like the tubing. So materials and the exudate moving down the tubing when he was out, people would look at it and he would be convinced that everybody was staring at him. So we made a big decision and we moved him over to the Pico dressing. So we not really ever been used on an open abdominal wound with bowel present before, but we decided to give it a go since Andrew's one of those patients who shouldn't be here anyway, as he keeps continuously being told, but we're moving forward. So we changed over to the Pico on the 26th of August, and on the first dressing change, you can see there, massive change for him. He loved it. He found it comfortable. He found that it gave him total security, and also no one knew he had a wound anymore. So because of the small box and the wire, he's got a little way of winding his wire up. He's very OCD about his wire. He winds it all up, puts it in the little pouch and into his pocket, and nobody had to know that it was there. Just what he's just said. So self-conscious of the vac, the fluid moving, and it was almost a badge of honour. The Pico he loved, but he had to be careful. So the reason that he's put up there about the badge of honour with the topical negative pressure is because it's an abdominal wound. Nobody could see he had a wound any longer, which, although the dressing was great, he could get out and about from a dignity and privacy point of view. From a safety point of view, he was worried about people knocking into him or barging into him if he was in a supermarket or if he was anywhere else. So that was a sort of a bit of a thing that he had to fend people off, as he's written. And if there's a small leak, it buzzes like he's got a text message. So he finds that brilliant. So he knows now. He just doesn't have a beep. He just has that buzz. So it's fine for him. So progress. This was March, and this he hasn't put it up there, but this is what we call. We can't quite work out if it's a mermaid or a duck. That's his new thing now. So it's sort of changed shape, and as you can see, he's now got what he calls back his belly buttons. We're not quite sure which one is his belly button. He has two sort of areas that could have been, but he's quite pleased with that. But still in those areas that are left that haven't healed, we've still got peristalsis, and we've got peristalsis underneath the epithelialization as well. Although that new skin is now very strong, we've still got peristalsis very, very visible at times underneath that area of skin. But he's doing really well. He's really happy. He's got a good diet. He listens, and he is an expert patient now, really, because he does tell us what things are going on. So the move from the hospital to the community was not smooth. It was very difficult for us to discharge Andy home because of the fear in the community. So nobody wanted to take him on. He's quite mobile, so this is the only thing that he's got wrong now. He is quite a mobile patient, so the district nursing team weren't able to help us. And the practice nursing team, very, very difficult because they had never seen a wound like this before. We went out and did a lot of education with them, but they really didn't want to take it on. And it was very difficult for them in a busy clinic because you only get given 15-minute slots in most areas. And this dressing probably was taking, I would say, at least 40, 45 minutes. So to do that twice a week and give up those slots was very difficult and very difficult for Andrew to understand why it wasn't simple and why things didn't work properly. So what we agreed initially was that he would have one dressing change done in the practice, and he would come back to do one dressing change in the hospital, which sounds great, but he lives 45 miles away from the hospital. So because we're a regional centre again, he was coming back a long distance to see us. He went back to work. So the PICO and that thing has allowed him to go back to work. But unfortunately, going back to work has given him a lot more challenges with people not realising he's got a wound and not understanding that he's still unwell and he's still going on, because people don't think you're going to have a wound when you had surgery 2.5 years ago. They don't think you're still going to have that same wound now, and that's a massive thing. So surgical wounds are thought to heal within a few months, but we have got a lot of patients that are 2, 3, 4 years down the line are still suffering with that same wound, healing, breaking down, healing. So that was a big thing for him. And what's the normal? So for Andrew, he's had to understand a new normal. So he's no longer got a life that he had previously. He can't go back to the same role in his job. And both him and his wife and his daughter have completely had to change their whole lifestyle because of this. He's still got these fistulas, so still wears bags, which have to be emptied, and 2 of these fistulas are on his back. So when he goes to work, he has to be very careful to make sure the bags are emptied in the morning, because he has no way of getting them emptied during the day. So all of those things are very important to him. Problems, these are the things that he sees are the problems. And again, they wouldn't necessarily be the things that, as a clinician, that we would think were the most important. Firstly, his weight loss. He was 55 kilos when he left hospital after coming in at 105. And for him, that was huge, not only in terms of the good nutrition, but also in terms of clothes. So for him, he couldn't find clothes that were comfortable and would fit around his waist and would fit around the wound, because obviously the abdominal wound is covering his whole abdominal area. Sterile scissors in the community. Can you believe that you can't get sterile scissors on prescription? I was absolutely gobsmacked when I heard that, but you can't get sterile scissors. So if you want somebody to have a sterile dressing done aseptically at home or in the surgery, they have to buy their own scissors, which just seems very ridiculous. But that was a big thing for him, and actually getting the dressings, because every time he went to the pharmacy to reorder his prescription for his dressings, he kept being told that they were too expensive and they needed to change them to something different. So for him to be told that is really difficult when the clinicians are prescribing a certain treatment which is working and is maintaining his quality of life. He then had to fight at the pharmacy every time, and he still has to fight at the pharmacy every time to get the dressings that he wants. And they would give him something that wasn't quite right, so made by the same company but the wrong product, and when he would say that it was the wrong product, he would be questioned by the pharmacy. So that's been very, very frustrating for him. And it's something for us to learn, that if we are in the community or we're sending patients home, to make sure we write lists of exactly what dressings that should happen with the wound, and maybe visit or phone pharmacies just so that they're aware of the background of what's going on. So we've learnt a lot as a team sending patients home from hospital from that point. Long-term healing, the skin periodically gives up. As you know, wounds start to deteriorate as the patient becomes unwell. So with Andrew, he does become unwell quite often because they still can't quite understand what's going on with him and what the future holds for him. So that still tends to be an issue with him. They said it would become life-changing and becoming a diabetic. He is an expert in diabetes type 3, which he continuously tells the junior doctors when he's admitted that he's a type 3 diabetic, and half of them question him. There isn't type 3. So he is an expert on type 3 diabetes, but again, he's had to learn to live with diabetes as well as everything else that's going on. And outpatients appointments. Very, very good point made this morning in the presentation given about getting our patients to know what's going on, but also to read their notes. So Andrew has never really drunk in his life, but attended one outpatient appointment. The doctor didn't look up, it was a locum doctor, didn't look up from his computer when Andrew and Lisa walked into the room, and then looked up and said, "So, have you given up drinking then?" So obviously thought that the pancreatitis, etc., had come from alcohol issues, which he didn't have, which really didn't bode well for the rest of the appointment, when Andrew was absolutely furious and actually felt really worried because it wasn't his normal doctor anyway, but then to think that there's a doctor there that hasn't even read your notes, that doesn't know anything about you, isn't really very good. So again, it's about talking to your patient and making sure you know what's going on with your patient. I think that was a big point that he wanted to put forward. And then for him, just his thank yous up there. It's very interesting when you see who a patient decides to thank, and the housekeeper made a huge difference on the ward. The housekeeper, how wonderful is that? That she obviously made such an impression on him that he wanted to say that the housekeeper and my hospital room cleaner, they obviously were communicative and worked well with him. So I hope that gives an overview. It's an absolute travesty he's not here, because he just speaks so passionately, and I'm sure I haven't given the passion that he would have given about his experiences. But really, the whole thing is to try and think about your patient's experience as well. And it's so lovely to see that some data is being collected on this, because we don't think that patients with surgical wounds have the same quality of life issues all the time as we do for patients with chronic wounds that are more common, so with leg ulcers and pressure ulcers. We seem to concentrate on those, but patients with surgical wounds have exactly the same issues, if not sometimes more issues, because they're more independent and they're working and things are going on. So thank you very much on behalf of Andrew.